SICS, and it is going to be one of the prized sessions. So welcome. The first speaker is Dr. South 2mm MSICS, my experience, Karamjit Singh. Karamjit Singh is there. They should do their job. Moderator and conveners, they know their responsibility, so they should be on the chair. They are not invitees, they are people in charge of the session. Karamjit Singh is there. Okay, Karamjit Singh is not seen, so veteran speaker Boramani's customized incision cataract surgery, Nita Dodwar. She is opening the session. Those of you who are doing SICS, watch Nita's presentation if you want to have cataract surgery without astigmatism. Boramani has wound modulations thing you must learn properly.
Thank you,
Nita.
sir. Thank you very much. Good afternoon, one and all. It's my pleasure and privilege to be a speaker of this Magic of SICS Session 2. Thanks to AIOS, APAO and ISM SICS for this wonderful opportunity. Today I'll be talking on a very innovative technique, that is Dr. Boramani's customized incision cataract surgery. In recent years, the advancement in cataract surgery has really raised the patient expectation of a visual acuity and the surgical result as well. And the astigmatism has definitely a very important impact on the final visual acuity. The prevalence of astigmatism is definitely significant among the cataract patients. So there are different options which are available for the astigmatic management. Here I'll be talking about the scleral wound modulation and its impact on the astigmatism. So here I'll take you through examples. We see in first photograph the corneal topography pre-operatively of a cataract patient, 0.13 diopter. Patient underwent the scleral modulation surgery, and post-surgery 3 weeks the corneal topography shows 0.17 diopter. So there is no surgically induced astigmatism. Second interesting example of a higher astigmatism, here we see 2.04. Here patient opted for the autofocus lens, that is a multifocal lens, and patient underwent the scleral wound modulation surgery. Here we see the post-operative corneal topography value of 0.43. Attoref shows 0.25. Patient is enjoying 6/9 and N6 vision. So these two examples shows us when the patient did not have any pre-existing astigmatism, patient underwent customized incision cataract surgery and there was no induced SIA. Second patient we saw higher astigmatism, patient underwent customized incision cataract surgery and that was treated with the scleral wound modulation. So definitely scleral wound modulation has an important role to play to manage the astigmatism. Now the present literature tells us what is the advantage of phaco over SICS is that it induces less astigmatism, but there is no available data how the scleral wound modulation has a good impact on the astigmatic management. So the principle is very simple. If your incision is straight, large, that induces the astigmatism of 1.25. And as you go away from the limbus, that your incision becomes more and more curved, the induced magnitude of your astigmatism is less, as only the central part of the astigmatism takes place. So I'll take you through the algorithm which is derived from Dr. Boramani's study, and this will help us for the scleral wound modulation. If we have a incision of a 7 mm, superiorly it induces the astigmatism of 1.7 diopter. Further reduction in the size of incision reduces the magnitude of astigmatism. Superior curved incision further reduces the magnitude of astigmatism, as we see in the center. Perfect U-shaped incision literally does not induce any astigmatism. As we are aware, the temporal incision are weak in neutralizing or inducing astigmatism. Temporal straight incision of 7 mm induces or neutralizes only 1 diopter of incision. As the further reduction in the size of incision reduces again the magnitude of astigmatism, and temporal curved incision, they do not induce any surgically induced astigmatism. So this slide is very important. So here we say the principle of customized incision cataract surgery is that you will have to place your incision, center your incision on the steep meridian. So whatever may be the size and the shape of the incision, so the vector forces acts on both the sides and helps in neutralizing the astigmatism. So this is the slide showing the surgically accessible area for the customized incision cataract surgery. So to get a perfect desired scleral wound modulation, find out your own SIA. There are different calculators available on internet. Find out your own SIA for that particular type of incision. Insert your K1, K2 preoperatively and postoperatively. That will help for the perfect scleral wound modulation. Again, I'll take you through few more examples of different magnitude of axis, different magnitude and axis of astigmatism, and how this scleral wound modulation helps in neutralizing. Here we see a preoperatively 0.28. Patient underwent a perfect U-shaped superior incision, and there is hardly any induction of SIA. Here is a little higher astigmatism of 1.12. The axis is 97. Superior straight little large incision has neutralized the astigmatism to 0.15. So here again a slightly higher astigmatism, 1.24. Look at the axis. The temporal straight incision has reduced the further astigmatism. Again a higher astigmatism. Here the patient opted for a multifocal without toric. So we see a magnitude 1.97. A straight superior nasal incision with the multifocal lens. The post-operative corneal topography shows 0.15 diopter, and patient is enjoying 6/6 N6 without toric. So the axis reference marking is done when the patient is sitting position, and the axis marking is done when the patient is a lying down position. Here is important to mark that once you mark your steep meridian, center your incision on the steep meridian. So the other video also shows the 39-degree axis marking, and the straight incision is centered on the steep meridian. So this customized incision cataract surgery and its impact on astigmatism was published in the prestigious Journal of Indian Journal of Ophthalmology. So here the surgically induced astigmatism is innovatively used to treat the pre-existing astigmatism. So it is a surgically corrected astigmatism. Here the incision is no more small, but it is customized as per the pre-existing astigmatism. So the proper terminology would be here, the customized incision cataract surgery. So few important take home points. The top priority always is the patient safety. So once you are fine with any grade of a nucleus management through relatively small incision, then you start planning this. First, find out your own SIA. Second is preoperatively know the astigmatic magnitude. Magnitude will help to decide the size and the shape of the incision, and the axis will decide the site of incision. Mark the steep meridian and center your incision. So to start with, you start with the accessible area, maybe superior or superior temporal or temporal, that will give the good results. So customized tunnel engineering will definitely help out, or at least minimize the stigma of astigmatism. Thank you for attending and patient hearing.
Thank you, Nita, for a wonderful presentation. Those of you who don't know, our friend Dr. Burma is from Australia, and he has been the RANSCO president there, and we saw his presence, big presence there, and doing a lot of wonderful work in Australia. And Dr. Vignesh is the president of our chapter. He is the chairperson, and I'm so happy that you are here. Okay, and our next speaker, Karamjit, are you ready? Okay, so our next speaker is RIO Amritsar Chief Karamjit Singh, a wonderful human being, a prolific surgeon, absolutely humble and but good in his work. He is training in 2 mm to his students, and he has given thesis to his student to on 2 mm MSICS. Karamjit, please.
Thank you, sir. Good afternoon, respected chairpersons. So my presentation is basically what I learned from Dr. Sahu's 2 mm manual small incision cataract surgery. So as we are discussing these days the construction of the scleral tunnel and the size of the incision. So the scleral tunnel, it is basically evolved for years. So we started with the type of incision, then we went on site and size of incisions. So mostly previously it was debatable that the temporal incision is better, spirotemporal is better, or superior is better. But now with the reducing size of the incisions, we can overcome most of the complications or most of the outcome which is there post-operatively. So these days we are basically doing topographic guided incisions on the steeper axis as discussed by our previous speakers. So with 2 mm manual small incision cataract surgery, one can have a better control over pre-existing corneal astigmatism, and it also reduces post-op astigmatism almost to negligible. So incision construction, it is very much important. So I am showing one of my initial videos. So basically I am practicing 2 mm incision, which is approximately 2 mm, 1.5 to 2 mm behind the limbus. So the initial incision is 2 mm, and after that I give back cut of approximately 2 mm, rather exactly 2 mm towards the fornix. So practically the size is 2 mm only. So this the keratome and the tunnel blade which I am using, it is of 2 mm only, which is basically from the Epsilon. Although I have no financial interest, so these days 2 mm keratomes are available. So previously people used to ask that you are using 2.8 keratome, then why then the incision is not 2 mm, but I am using 2 mm keratome these days. So initial sclerocorneal tunnel, it is very easy to construct the tunnel with the tunnel blade if you are in right plane. So see, practically the incision is approximately 2 mm only. Then after that a good large capsular axis as usual, as we are doing, and a good hydro procedure to basically prolapse the nucleus into the anterior chamber. Good hydro procedures are required. Now the main part is nucleus prolapse, and after that it's a delivery out of the 2 mm scleral tunnel. So, so we prolapse the nucleus as we are doing in manual small incision cataract surgery. And after that, with Dr. Sahu's specially designed 2 mm vectors, so I hold the nucleus with good viscoelastic material, and with visco cannula I divide the nucleus into 2 pieces. So see how easy it is to divide the nucleus into 2 pieces. Even these days I am dividing into 3 or 4 pieces also. So then it is very easy to prolapse that nucleus out of the scleral tunnel. And see, there is no pressure on the scleral tunnel. And this is basically in the bag that I learned from Dr. Sahu only. So it is basically in the bag division of the nucleus into 2. So it is nucleotomy within the bag. And after that, this is also expression of the nucleus first into the anterior chamber out of the bag. Then after that, it is very easy to divide that nucleus into 2 or 3 or even 4 pieces, and with 2 mm specially designed vectors, which is easily available these days, out of the 2 mm scleral tunnel. And after that, we can implant foldable intraocular lens. If your incision is a little bit large, your tunnel is a little bit large, even we can implant 5.25 or 5.5 non-foldable intraocular lens also. So this is, I feel that this is very good technique. So so these are the few instruments that I am using for nucleus management. So these are specially designed by Dr. Sahu sir. Thank you, Dr. Sahu, for giving me this instruments. And after that, IOL implantation as usual. So basically I want to show the results. That video is not coming. So basically this technique 2 mm incision has all the advantages of phacoemulsification. It is less time consuming and few instruments are required. It is indications depend upon surgeon's experience, skill and expertise, but it is not a technique of choice for the beginners, and it has very less complications with the experienced surgeons. So I did more than 200 cases with this technique, and my astigmatism is average astigmatism is 0.8 diopter only, and there are few complications. For first few days we can encounter edema at the incision site at the sclerocorneal tunnel. Superior corneal edema may be there, and but that subsides after 5th or 7th day, and there are minimal complications. The average endothelial cell loss that we encounter, so we are going to publish the 200 series of 200 cases recently. The average endothelial cell count is approximately 150 only, and there are few complications after experience. So basically I want to show my results, but I lost my pen drive somewhere in this conference. That's why I'm presenting this, the previously saved my PPT. Thank you very much for your patience.
Thank you, Dr. Karamjit. See this, you are telling about the tunnel making with a 2 millimeters, this thing. Not necessarily. If you have a broader, cystotom sort of that thing, you can go from the side. If you go from the side and then take the pocket from inside, that will also, you don't have to go straight.
Okay, sir.
So you go from the side and fasten your pocket.
But these days, sir, 2 mm blades are also available.
Just telling you.
Yes.
If somebody says somebody is not having,
yes, sir,
it is not a handicap.
So we can use 2.8 mm also.
Sir, can we take questions in between or after talks?
Yeah.
Yes.
Yes.
Can we take questions in between? Questions from audience.
It is better you take the question now, and so that they can
Yes.
attend.
So any questions from audience regarding these two talks?
The procedure you showed that you practically broke the nucleus in the anterior chamber
Yes.
before taking it out.
Yes, sir.
Don't you think, I have two questions to make. If we make it in a separate side port entry, that will cause less drainage of the HPMC.
But sir, then there are more chances to touch the endothelium when we are inserting the second instrument.
I think it's the other way. Once you are putting both the instruments from the same one, chances of draining the viscoelastic is more. If you are making from side port, the chances of draining of the viscoelastic is less. You tend to get a deeper anterior chamber.
So sir, basically I am using the tapered visco cannula.
Achha.
So simultaneously I am injecting the visco in that. So
Achha.
there are
visco
less
pump.
chances of leakage of the
Understood.
that viscoelastic.
Achha.
So I am not using simple cannula. I am basically injecting the viscoelastic into the layers of the nucleus. So that separates the nucleus into two.
And the postoperative results, as it can make out, there will not be any astigmatism practically.
Sir,
But how good is the cornea going to be the next day?
sir, the next day, sir, we can find a little bit corneal edema at the incision side, at the 2 mm incision side, spirally or spirotemporally if you are doing spirotemporal. But that edema overcomes within 5 to 7 days. So little bit edema can be there if we are dealing with a little bit harder cataracts.
Yeah, with such small incision, you can very well go for any sort of foldable multifocals.
Yes.
Okay.
Any other questions?
Sir, yes, sir, practically the outer incision is 2 mm only. So as the sir said that we can use 2.8 from side. So the first incision is 2 mm only. So if we are using 2.8, the incision can enlarge, or there is a little bit buttonholing at the incision site, sir. So that's why so I searched from various companies the 2 mm keratome. So it is readily available now, 2 mm.
Another question actually is maybe for the previous speaker. I have been doing SICS for last 20-25 years, and the simple question is, we are taking care of the corneal astigmatism part of it. Whatever we are doing, we are taking care of the corneal astigmatism part.
Yes.
I have come across cases where preoperatively I have hardly any corneal change, postoperatively cornea is very fine, not much of astigmatism. Even then, I am getting -2 or -3 cylinder, which subsequently I tallied with the auto-ref, it tallies there. Must be he was having some denticular astigmatism
Yes.
or some other. Is there any way to take care of that part?
Sir, see, this is that's why we have a research platform now, Vertical.
Yeah.
So you do focus on that. He is focusing on something, you focus on that. He is not focusing on this.
Other parts of the astigmatism. Yeah.
So you take over from there now. You focus and bring your some paper.
Sir,
So
we can manage the corneal astigmatism
Yeah.
with the incision construction, the size and site of the incision.
I said the same
But-
with phaco also.
No, sir,
Yeah.
to answer your question, you said that the post-operative K values are almost similar, but you get a result of -2 or something in the outer F finding.
Yeah, that's it.
So that means there is a lens still.
Yeah.
So that means there is a jonular weakness somewhere, or one of the haptics could be above and another could be below the rexus
And
margin.
that was there previously also. Subsequently, I checked in the previous case, autograph readings, that used to show -2 or -3 cylinder.
See, it is not possible that
You can't correct by that.
No, if you have a lenticular
time
post
हो जाएगा वो।
surgery,
Yeah.
there is
I
no
thought
more
you
lenticular
can
because
go
it's removed.
somewhere else now.
So if the
So I wanted to
haptic
finish
is
it.
placed exactly parallel to the cornea, corneal plane or pupillary plane, there should be no astigmatism because that is removed. Theoretically,
Okay.
you cannot have a K value having 0 and a lens parallel to the limbus and still having -2 cylinder.
Okay. So we will now go for the next speaker.
Thank you, sir. Thank you.
Dr. Saus 2 mm MSIC ergonomics. Dr. Nilutpana Deori is from Assam, a brilliant surgeon, dedicated surgeon also, and I thank her for confirming with my postulations, and she developed the ergonomics and whatever. Yes, Nilutpana.
Thank you, sir. Very good afternoon to all of you. Thank you, APAO and AIOS for giving me this opportunity. I would like to thank ISMSIS for giving me the responsibility to tell you something about the wound ergonomics of 2mm MSICs with back incisions. I do not have any financial interest in this presentation. So as we all know, we are looking at 2mm incisions, but I would like to say that this is an advanced MSICS technique which has got 2mm curvature on your scleral incision only, but then you need to place 2 parallel incisions on either side of the 2mm, which will help you to create the pockets once you enter the cornea. So with this algorithm, I am showing you this schematic diagram. In this diagram, this incision is placed 1.5mm behind the limbus, and the 1.5mm incisions are placed on either side of the incisions of the main incision. So you when you are creating scleral pockets, you need to understand that the scleral pockets are going to go into the cornea up to 1.5mm. And this incision, since it is a curved crown incision on the outside, so we need to keep in mind that the entry into the corneal wound will be parallel to that of the limbus. So I have made this incision, as you can see, distance of 3 to 6mm. Now the reason why I have done that is that in order to manipulate or maneuver your instruments, that is the vectis and the nuclear fragment in the tunnel, you need to at least expand it to 3 to 4mm. Why? Because the cornea is not expansile as the sclera. The elasticity of the sclera is more. So you get the advantage in the sclera, but you do not get the advantage in the cornea for that matter. And we have numerous papers, especially one by Singer, which says that you can introduce a PMMA IOL even through a smaller scleral incisions. So now to understand the physics of the procedure, we have created a model like this where the object 2 is the nuclear fragment, object 1 is the vectis that will be in the tunnel at one point of time when you are going to take it out, and the red arrow shows the direction in which it is pulled. But I will explain it to you later on that this is not the ideal direction that should be used, and the surface is the scleral bed that you have created once you have made the corneoscleral tunnel. And the force T on either side is the tension that will be acting on the 2mm incision at all points of time. In order to reduce the stress on the 2mm incision, you need to create the back incisions and create the side pockets along the back incisions. So as I have explained, we have the elastic region of the eye, that is the sclera, and the plastic region of the eye, that is the cornea. By means of the Hooke's law, we know that when the stress is within the proportional limit, the membrane will return to its original length, that is the scleral wound, when the objects are out of the tunnel. But if it crosses the yielding point, that is the point C, then you will see that there will be fraying of the ends of the tunnel, there will be fish mouthing of the scleral wound. So if you want to have a good wound integrity, you need to understand this point before you go ahead with the surgery. This has already been shown by my previous speakers, the instruments that you want to use. So I'll go ahead with the surgery. So this is a 2mm marking that we have done, 1.5mm behind the limbus. You make an incision here, and then you place the side incisions on either side of the 2mm incision. Now if you do not have a 2mm crescent, go sideways on either side. Now why I am saying this, because if you want to create a 2mm and go with a larger size 2.8 or 2.2mm crescent, you will actually cut the ends and you will end up with more than a 2mm incision, because since your sclera is elastic, it will give away, but it will not, it will again contract back when it is healing. So you are actually not doing a 2mm incision, you are actually making a 3 to 4mm incision. In order to avoid that, these back cuts are very important. It is also good if in this situation you are ambidextrous, so that you can use both hands, because this is a very small incision. Now this is a 2.81, so that is why we have gone obliquely or diagonally. So once you have entered it, see, we have created a parallel incision now, but I have increased it here. Here I am planning, according to Singer's hypothesis, that I am going to implant 5.5 optic PMMA IOL. Now when we are trying to fracture or fracture the nucleus in the anterior chamber, we need to keep in mind that the visco cannula has to inject visco throughout the process so that we do not injure the endothelium. And you have seen that at single go, the one fragment of the nucleus has actually come out. So even at the end of the surgery, you have already created a tunnel, and the successful execution of the process, that is pulling out of the pieces of the tunnel without tearing the scleral tunnel, won't indicate that all the stress that is developed in the scleral membrane was within the elastic limit. So now let us do the analysis. The size of the nuclear pieces and width of the tunnel. This can be explained by the Pythagoras theorem. I have used a very simple theorem to explain this to you. That when you have that the stress is equal to the restoring force and the area that is occupied. So the amount of stress will keep on increasing if you increase the restoring force. That is why you increase the area so that you reduce the stress. Now as you go behind, you will feel that as the L decreases, the restoring force T increases. So since the stressing force T experienced by the membrane is higher near the scleral incision, the only way to keep it low is to proportionately increase the area, and which we have done by making the pockets on either side. Now we'll analyze the width of the tunnel. Now since the restoring force increases with the size D of the nuclear piece, so you cannot bring out the nucleus in toto, you have to divide it. Otherwise what will happen, you have not created, in this GIF you can see that I have not created the back incisions before taking out the nucleus. So what has happened, you have actually created a fish mouthing, and when you have created a fish mouthing, there is a purse string effect on the entire tunnel that will pull, that will act at that point in the tunnel. So you are not having a 2 millimeter incision anymore. You are actually having more than a 2 millimeter incision, and that too with frayed ends. So therefore the minimum length of the tunnel and the maximum size of the nuclear piece and the minimum thickness of the scleral membrane is such that the stress is below the scleral limit. We have another paper from the Indian subcontinent by Dr. Ashok Nanda et al. Who actually described regarding the thickness of the scleral tunnel. So you need to understand that when it is at least 1/3, or if it is a little more, you will have less stress on the wound. But you cannot go beyond, you cannot increase it to 400 microns and so on and so forth, because otherwise you will have a premature entry. So now how do you pull the vectis? So when you have entered into the tunnel, and now you have the vectis and the nuclear fragment in the tunnel, not inside the AC, but in the tunnel. At that point of time, you will have another two forces acting here. One is the horizontal force that is on the ends of the incision, and another is the weight, that is the sine alpha and the cos alpha forces. Now you have negated the cos alpha forces here because you have already created the side pockets, but you cannot negate the sine alpha forces because it will double up now. Why it is doubling up? Because you have the vectis, you have the nuclear fragment inside the tunnel, you need to pull it out. So for the horizontal pull F given by the vectis, the friction N between the vectis and the scleral membrane will cover the weight of both the objects 1 and 2. Hence the material of the vectis should be lighter, and in order that the acceleration of the nuclear piece
can you sum up please your conclusion?
Should be less than that of the sliding force. So you need to have viscoelastic inside. So now you cannot have a horizontal pull at all points of time. In order to reduce this friction, you pull it at an angulation where there is a little upward push and a horizontal push, such that the scleral tunnel is not injured. So this is the right way of doing this incision to have a clear cornea on the next day and a good wound integrity. But if you create a 2 millimeter and do not create the side pockets, you will end up with iris prolapse, you will have corneal edema. And this is what we have realized after our experience at 2 millimeter, and we feel that astigmatism, wound integrity and the corneal endothelial count was valued in good limits. So thank you for your patient hearing.
Thank you, Nilit, for a wonderful presentation. Our next speaker is Ramesh Shah. He is from Bombay, an innovator and a person who can make you a millionaire, because he is wizard in the financial investment in stock exchange. Welcome, Ramesh. Listen.
Thank you, Dr. Boramani and Dr. Sahu, to invite me for this keynote address. What I learned in last 5 years from our innovations, I believe in performance and not perceptions. I will divide my talk into these categories. In cataract, OmniGlow and Video Glow is the best choice for any microscope. It gives seamless red glow for the best depth of focus. Our video recording system with NASA grade camera is the best at an affordable cost. Cases of drop nucleus, corneal decompensation, all are reduced drastically, bad for the retinal surgeon. OmniGlow is the biggest gift in ophthalmic world all over the world. It saved 900 crores for ophthalmic world as we sold 4,000 OmniGlow across the country. We expect similar response from our Video Glow.
With OmniGlow, omnipresent, homogeneous and uniform and full red reflex with greatly enhanced stereopsis is 100% guaranteed in any position or any tilt of the eyeball.
You can see wonderfully the flow of the viscoelastic.
And they all have said that due to better glow and stereopsis, incidence of PC tear rent have decreased significantly, and by rare chance if it happens, the management of PCR and vitreous prolapse has improved a lot. And or IOL decentration induced by decentered capsular overlap. With OmniGlow, we can easily avoid all such late complications right at the time of surgery.
The second part of cataract is importance of Purkinje's image, especially for the multifocal lens. It helps you to locate rhexis perfectly. It helps in placing the IOL right at the center of the visual axis. Second part is eccentric rhexis in case of mature cataract. Refined blue staining has to be there for minimum 1 minute before you start the rhexis. It induces C3R changes on the capsule, especially the mature cataract, and this helps to avoid Argentinia's flag signs. This is the way you start in the eccentric thing, it go all around. Third part of cataract is astigmatic keratotomy up to 2 diopters, which I think Dr. Buramani and Dr. Sahu has already told in SICS. From point, this is the nomogram which I used. You take the steep astigmatic keratotomy of 90% of the depth. This is the the blade which I use, calibrated blade, which is cash-based blade, which I purchased about 30 years back. We fix it at about 550 to 600. Make a 1 incision, 1 stroke, and then again go back so that you have a uniform 90% thickness of the astigmatic keratotomy. All the diopter corrections are done on the basis of IOL Master 700, Pentacam or Holiday cataract formula. Do not do AK in a pre-keratoconus or keratoconus cornea. AK reduces my toric implantation from 3 per day to 1 per week. Now coming to in cataract, the IOL selection which I have decided, which I have learned in last 3-4 years. Autofocus progressive polyfocal IOL. It has no diffractive rings, or a various EDOF IOL can reduce the quality of vision for near or distance and have relatively high rate of dysphotopsia. Autofocus Pro is my first choice of IOL. Polyfocal progressive lens, measurement of DOF is absolutely mandatory in all our IOL surgery. This is the largest lens in the world at present, 7.25 mm horizontal and 6.25 vertical. It has it eliminates the negative dysphotopsia because of its large lens. This is the depth of focus which is absolutely necessary in case you want to have a spectacle free happy patients. It occurs in 85% of the cases with Autofocus Pro. This is one example. Coming to the LASIK which I learned in last 5 years, 100 micron flap is better than 90 micron. 100 micron flap has lowest rate of epithelial fold. This is one concept which I feel is new, and it reduces the incidence of stromal folds. Customized aspheric ablation based on spherical aberration is a must. Ablation zone and transition zones are decided according to size of the pupil, photopic and scotopic. It reduces chances of negative dysphotopsia to near zero. A spherical aberration based ablation gives 6/4 vision in 85% of the cases. It also increases depth of focus. Epithelial maculing pre and post LASIK for unhappy patients. EpiLASIK is I started doing epiLASIK in some of the keratoconus suspected patient with normal epithelium. LASIK, surface ablation, PRK or LASIK with the flap is far more superior than SMILE for quality of vision. At present, SMILE does not have customized or aspheric ablation. Only 8% of the patient with SMILE improves the vision by one line. Concentrate on customized spherical aberration profile ablation rather than going for making a various flap for the sake of money. This is the perfect aspheric ablation. If you see in the central portion, the ablation is more, then it will little less. So the first central portion, then it is about 60% in the periphery, and then rest of the thing is there. So it creates a very smooth ablation zones. Depending upon the size of the pupil, you can change these zones. Coming to the cornea, use of Rho kinase, which we started with Dr. Kakadia. Molecule 27632 has for 3 months stored at less than 4 degree temperature as a local eye drops. 27 eyes are treated with that, and the corneal decompensation reverts without keratoplasty. In case of viral corneal infections, I remove epithelium with alcohol on the day 1. It reduces the viral load for the faster recovery without corneal opacity. A green light with rose bangle will be the future to treat the corneal infection.
Please notice the difference between corneal bandage lens and the Terrigo, the scleral bandage lens. Let us see the specifications of Terrigo lens. It is 21 mm in diameter. It is made of high water content hydrogel having 75% water content with highest possible oxygen transfer capacity. It is having peripheral soft skirt with slightly firm and more thick central optical zone, which provides a slight vaulting, keeping a potential tear film of approx 50 microns between lens and the cornea, and it can be kept in eye for 24/7 for 4 months at a stretch.
Without removing the contact.
Terrigo lens is also very much useful in almost 15 other indications.
Now, uses of Terrigo, 7 eyes, which what I am telling you the statistic which I have used it. 7 eyes with irregular cornea including keratoconus and post-RK. 2 of them are for recurrent erosions. Adenovirus infections, which we removed the epithelium and put the Terrigo lens. Herpes lesion also we have used the Terrigo lens. 2 cases of bullous keratopathy with painless eye for last 3 months. Maximum duration with constant Terrigo was for not 8 months. It is not 10 months, it is 8 months. 1 patient could not tolerate, so we removed the contact lens. This is one patient which has come from Saudi. He's gone very bad care, RK done. His vision improved from 636 to 612, and he has put this lens for 4 months before.
Its material has very high affinity for moxifloxacin, so it is a drug delivery lens which it absorbs very fast and retains long and well, and slowly releases moxi over many hours, so putting moxi eye drops twice a day is enough. Thus, understand it as not only a bandage lens but as a sort of a medicated bandage lens.
This is one patient which we could see the moxi glow on the side of the contact lens, the edge of the contact lens. Coming to the glaucoma, TUG means treatment of ultrasound for glaucoma, for open and pseudophakic glaucoma. It's an ultrasound treatment for clean trabecular meshwork. OmniFlow is the second part of it. With uncontrolled glaucoma, it's a retrobulbar or suprachoroidal drainage device. It is the first device in the world to drain the aqueous relative empty space of retrobulbar space. OmniFlow should be a primary choice for at present we are doing for the congenital glaucoma.
While giving 30 watt energy at phaco tip, we are unknowingly also giving 3 watt energy to opposite one quadrant of trabecular meshwork.
This is under the process of FDA
So we thought that if ab internal ultrasound in OT can lower intraocular pressure, can we achieve it by non-invasive ab externo approach in OPD or as an office procedure? Traboclean is as good as cleaning a blocked tea strainer. OmniFlow is a unique, novel, small and the best glaucoma drainage device, which is a shooterless short shunt.
One from UK
to drain aqueous humor from anterior chamber to the retrobulbar space.
PC marking recently last year.
With OmniFlow, the IOP is down from 60 to 80 to 10 to 12 as soon as the tube is in. The microvalve regulates the IOP, keeping always above 10 millimeters of mercury. It gives excellent results in all severe, intractable, bloody and oily open-angle glaucomas. It is a quick 10 to 12 minutes, almost sutureless surgery. Omniflow Supra is another version of Omniflow. Omniflow Supra is a suprachoroidal tube shunt for BAGS, BAGS, that is bleb-free ab externo glaucoma surgery. It drains the aqueous humor from anterior chamber to suprachoroidal space.
Third one is a keratoconus. Epithelial mapping is a very important thing. If it is not thinning over the cone, that means the keratoconus is not existing. Epithelial mapping does not follow the same pattern after the age of 45. Comparison of epithelial mapping pre and post C3R will help us the effectivity of the treatment, and green source of light with rose bengal will be a great tool for keratoconus in future. We have already done about 10 cases of keratoconus with brilliant results and K flattening up to 5 to 6 diopters. This is one thing you can see, the epithelial mapping which is thinning over the cone, same place. This is the one where we have treated with keratoconus, the C3R. From thinning it is gradually becoming the same one, the means uniform over the cone. Moxiglow is another one with the UV light, since the time is not there. So conclusion is always stay ahead of the technology. 6x4 vision is possible in 80% of the case, 80-85% of this spherical base, flap base LASIK surgery. 6x4 vision is very rare in smile. Spectacle free for all the distance without dysphotopsia is possible with varifocal 7.5mm autofocus pro. Newer modality will be reality in glaucoma treatment, including like TUG and Omniflow. Monofocal IOL must be replaced, that's what I feel, with a ringless, any ringless, varifocal or other one. Bifocal spectacles are normal, at present are replaced with the varifocal glasses. Almost everybody wears varifocal glasses. Treat the patient with the patient's need, not their pocket. Always believe in performance, not perceptions. Earn for yourself and not for the companies. Our future innovation is phaco-like machine which you are going to create in 1/10 of the cost for SICS surgeon is almost done. Autofocus video system which we have created will be less than 1 lakh rupees for the quality of other system which is around 20 lakhs. Casbier astigmatism of knife, we are going to make it, at present is available at 3 lakhs. We are trying to bring down to 25 to 30,000 rupees. And green light at present C3R machine which is about 24 lakhs, we might bring down to 1.5 lakh rupees. An affordable TUG machine which is 34 lakhs now, we might bring down to 10,000 rupees. With this, thank you so much all of you.
Yeah, thank you Dr. RC for lovely presentation, and I am sure there will be many questions you will be answering after the session outside the hall. So the next, next I'll invite Dr. MS Ravindra, who is going to talk on MICS in challenging cases. And by the time he will be finishing, the next speaker should be on the next podium, please. And next speaker will be Dr. Deepak Meghur.
All of you must be knowing MS Ravindra is a wonderful teacher and a wonderful surgeon.
Good afternoon, my friends and my colleagues. This is the way I do a routine cataract surgery. I take a direct incision in the anterior sclera, go across the limbus and on a virgin conjunctiva. And this is a case of microspherophakia. With very high pressure, the patient came. I have done an iridectomy there, which is not relieving the pressure. So I resorted to a surgery. How to do a rexis in such a patient? What are the options we have? Suddenly I decided that I can hold the capsule with two instruments. On the left side with an MBR blade, on the right side with a cystitome I made punches, otherwise it's impossible to puncture this anterior capsule which is released from the zonules. Now with the rexis forceps I can hold the anterior capsule, and like a handle holding the bag, I call it as a bag holding bag handle technique. I'm doing a rexis and I could support the entire lens in spite of the very lax zonules, and I could complete the rexis. What next now? If I remove the cortex and put the lens in the bag, it's going to dislocate at some point of time. So normally I would have removed the cortex and I would have removed the capsule, and did a vitrectomy, and then I would have put a PC lens supported by the iris. But here suddenly at one point of time I thought, why not retain the posterior capsule? So I'll avoid the damage to the zonules and ciliary body by tractions, and the entire capsular bag is present, and in front of it I put a iris claw lens and enclaved it behind the iris. This is a very unique technique. For the first time it's reported in the literature. I have not reported, but the first time I hunted the literature, it's not there anywhere, so I could do it. So what happens, this case, does the PC pacify later? I've been doing this for last 4 years now, and all these pieces are clear magically. I do not know how. Maybe there's a concept which makes the PC clear. And here again, as you can see here, when I did the rexis, there was a lot of zonulopathy, and here again this is going to dislocate. You can see the lot of IFIS there. I've removed the cortex, and again I've done the entries on the side. I can't put a PC lens here because it's going to get dislocated later. So the same concept I've utilized for a patient for an eye where zonulopathy is extensive, which I detected accidentally during the surgery. This was not diagnosed preoperatively. So you can see the rexis margin there. Obviously it is sitting. And the lens is supported posteriorly by the posterior capsule, and anteriorly it's held by this. It will never get dislocated. This is a classic case of, it looks like, posterior capsular cataract, and we should be very careful in such patients, otherwise you will have a rent in the posterior capsule during the surgery. The SICS being a very low pressure, low flow technique, I'm not bowing or pressing the posterior capsule backwards. This is probably the ideal technique for any presumably posterior capsular cataract. So now you can see you should be very careful. Anterior chamber is very shallow, it's not deep, and I'm not pushing because the pressure in the entire eye is atmospheric or less than atmospheric right now. I could put a lens, and without any problem I could have completed the surgery. So this is one good indication for SICS where you suspect posterior capsule to be dehiscent or potentially weaker. This is again a case where a Morgagnian type of a cataract, as it was explained by Dr. Amesha just now. The trypan blue staining will help you in doing a good rexis. It will stabilize the texture of the anterior capsule. I have enlarged with a 5.2 blade. I completed it. All of you are familiar with this technique of doing rexis or double rexis or a spiral rexis. So then I went and completed the rexis in that patient. What I am trying to tell is, it is so safe. I can predict that I can get a good rexis even in this patient all the time without any runoff or an Argentine flag, because of a technique called tunnel floor entry technique, where I deepen the chamber, enter while doing the rexis, enter through the floor of the tunnel, and then I finish the rexis. That's what I did in this patient. It's a very hard cataract, fibrous cataract, and then I could cut the nucleus into two pieces with continuous irrigation of visco in front of it using a cystitome. I don't have any special gadgets for that. Remove the entire cataract, remove the cortex, and then the patient had opted for a multifocal lens, and I have no hesitation in putting a lens of multifocal nature even in such mature cataracts. I was told that many people refuse to or hesitate to put the... This is one technique where I slit the top of the cartridge of all cartridges, so that the lens goes inside beautifully without any pressure on it. See, the lens immediately after putting, you don't see the crease that you get on the lens. So that's my presentation. If there are any questions, I would answer it. The idea of it is the technique of SICS is a low pressure technique where throughout the surgery you're not increasing the pressure. It's got too many advantages. The second is flow of fluid is only about 30, 40, 50 ml. You can finish the entire surgery with that amount of BSS. Third thing is it's a very simple surgery, but then it needs as much attention, as much training as a good phaco surgeon. Don't think that it's a very easy surgery, but then it is not a step to learn phaco surgery. It's an end by itself. Thank you.
Thank you, Dr. Ravindran, and it's so great to see you after so many years. May I now invite Dr. Deepak Megur to talk about M6 in complex situations. He's not here?
He's not here.
We'll move on to my dear friend from Perth, Dr. Vignesh Raja, talking about strategies for zonular dialysis. Vignesh.
I'd like to thank the ISMIC Society of India, Dr. Sahu and Dr. Boramani, and my colleague and mentor, Prof. Verma, for this invitation to speak at this meeting. So I'm going to talk about strategies for zonular dialysis, and because I thought it was an SICS course, I should only present cases where we've done SICS for zonular dialysis. So this is a video that was, because normally we do lots of phaco in Australia, so I borrowed this video from my good friend and colleague, Minu Mathan. So let me play the video. So here you can see that as you're doing the rexus, the lens is very wobbly, and you do very gentle hydrodissection. And looking at this, you can see how wobbly the lens is, and you can see one of the poles of the equator already lifting. So the next thing is, when you're trying to tumble the lens out, you don't want the whole bag to come out and vitreous to prolapse. So here we're using iris hooks for the bag, so that we keep the bag stable, and insert a CTR through the side port, because it's nicer to insert it through the side port, because the CTR you don't deform it too much. You actually follow the curve and it goes in very nicely. After gentle hydrodissection, we just tumble out the lens very slowly, and then with the vectis we take the lens out. So back then we used to put lenses in the bag, but now the thinking has changed, because with the advent of capsular phimosis, these lenses can decenter. Even despite putting a CTR, they can still decenter. So now the current thinking is that we put a 3-piece lens in the sulcus with optic capture. So when you have an unstable bag, I think that is the preferred way to go, because these lenses don't then develop late onset capsular phimosis, and they stay well centered, and they also don't decenter as well. And again, when there is a CTR, always strip the cortex tangentially and not radially, because then it's easier to come out. And best is to put a 3-piece lens in the sulcus. This is of course when you do it with mild degrees of zonular dialysis. But this is a case where I am doing this. This is a case in Australia, and that's why in the Magic of SICS session part 1, I said that every phaco surgeon needs to know SICS. You're not a complete cataract surgeon if you do not know SICS. This is a black-brown cataract sitting in the anterior vitreous of an indigenous person in Australia. So here, because it is more than 8 clock hours of zonular dialysis, I've decided to do, you can see the lens tilting down into the vitreous. And I thought to myself, I think rather than doing that, I'm going to do what I'm most comfortable with. I'm just going to remove the whole lens, do vitrectomy and scleral fixate a new lens, or you can even put an AC IOL depending on the surgery that you're more comfortable with. So I mark 2 sclerotomies, 4 millimeters apart on either side of the limbus. And because I want to tamponade the vitreous as much as possible. So that's why I put dispersive viscoelastic, and I take out the whole lens. And now I put a suture just to maintain anterior chamber stability again, because you don't want more vitreous prolapsing out, because if you do that, then by the time you go in and do a vitrectomy, you will find a tear or a detachment. So I first clear the vitreous from the anterior chamber, and this was in the pre-Lux Good era. So I was using an Alcon CZ70 BD lens because we've got such a big tunnel anyway. So I'm passing CV8 Gore-Tex suture, and I'm externalizing the suture and then put the lens in. Because we've got a big tunnel, this lens goes in straight away, and it's very well centered because it's a 7mm optic and it's a very big lens. So these lenses always center very, very well. And the best part about using the Gore-Tex technique this way is you're not blindly railroading a needle. So we've cut off the needles, and it's very controlled through the trocar cannula system. And once you pull out all the sutures, all the cannula, the sutures are there just to be tied up. And now instead of suturing the conjunctiva, I just suture it with glue, like how we do pterygium surgery. So apart from closing up the scleral wound, and we have to make sure that we bury the knots inside, because if you leave the Gore-Tex knots outside, you'll get scleral necrosis and conjunctival erosion there. So to summarize, for zonular dialysis cases, when you're doing SICS or phaco, it's always better to have a large rhexis, at least 5.5mm, because with late onset capsular phimosis, that can cause further decentration of the bag, intraocular and CTR complex. So and you can use capsule hooks, like either the iris hooks or capsule hooks, like Chang capsule hooks, because the Chang capsule hook goes all the way to the equator of the lens and supports that, and then you can place a CTR. And again, depending on the degree of zonular dialysis, you can use a single CT, just a normal CTR, a single CTR with a single Cioni ring, or CTR with double Cioni ring. And for lens placement, you can either do SFIOL, ACIOL, or iris clip, or a 3-piece lens in the sulcus with optic capture. And thank you all.
Thanks so much, Vignesh. Oh, so we have Dr. Megur here. Yeah, excellent. Yeah, he's going to talk about M6 in complex situations.
Respected Chair, Dr. Amulya Sahu sir, and the entire management here, thank you for the opportunity. And I'll be speaking on SICS in complex situations. So I'll just take you through a couple of scenarios here. And so there is no situation in which SICS is not suitable. Like, that is the reason why Dr. Boramani just always calls. I learned this quote from him, that there are few situations where phaco can be is not advisable, or it cannot be performed, but there is rarely a situation where SICS has to be avoided or contraindication. So so let us go through a few examples here. Now this is a posterior polar cataract. So in these situations, as we all know, there is a higher risk of having a posterior capsular tear, and of course we are avoiding hydrodissection. And one change which I have made here is I made an oval rhexis, which is longer in the longitudinal area and then shorter from the side. Well, actually this is proposed by Dr. Kiranjit Singh for phacoemulsification, but I feel that you can very well use this for the manual SICS as well. Now, because we have got because we have got a longer exposure in the subincisional area, maneuvering the nucleus out of the bag is relatively easy. We don't do hydrodissection using 2 Sins cubes. It is just wheeled out of the bag. Now, when we are going to pull the nucleus out, there is a momentary shallowing of the chamber, and this is when the posterior capsular tear can happen. So this is what I experienced initially. That momentary, whatever shallowing is there, that is what causes your posterior capsular tear to happen. In this case, the anterior hyaloid was still intact. The anterior hyaloid was ruptured, but the vitreous prolapse had still not happened. We can clearly see this round circular thing, which is the anterior hyaloid rupture, and this is the posterior capsular tear here. And this is a stage at which you push in OVD to push back the anterivitreous face and then perform posterior capsular rhexis. If the vitreous is already prolapsed out, and then you cannot do the posterior rhexis now, you have to perform vitrectomy and then perform the posterior capsular rhexis. But if you are still, the prolapse is very minimal, you can push it back with the OVD and then perform the rhexis. And then you're going to perform the antivitrectomy. The reason why we need to perform the rhexis earlier is because it's much more easier to do it in an eye which is not evacuated off vitreous, because vitreous gives us the support. If the eye has become soft, then obviously we can't, it becomes a little bit tricky to perform rhexis. And when you do a posterior capsular rhexis, inflating the bag and placing the lens will be safer. Otherwise, we are going to enlarge the rhexis when you're trying to maneuver this lens into the bag. So because we have got a very strong rhexis, you can place the rigid PMM lens into the bag and still don't have an extension of the rhexis. So now my question was, can we prevent this posterior capsular tear in these PPC cataracts? Because this was the step in which it actually happened, that momentary shallowing. So how can we prevent this? So I was thinking that this is another dense cataract with a posterior polar cataract, and there's a reason why I chose to do a manual SICS over the phacoemulsification. We performed the same steps. You have a large oval rhexis, but one additional thing which I did in this case was, during the delivery of the nucleus, I didn't want the chamber to shallow. At that stage, I thought it's better to maintain the chamber using an AC maintainer. I'm using it off late. I've never used AC maintainer before, but off late I find at this stage it is still off. It's not on now. But when I'm just removing the lens, that's the time when the AC maintainer is turned off. So here, another point here, we don't want a very high hydrostatic pressure. So if you keep an AC maintainer and keep the bottlet at 90 centimeters, you are going to blow out the capsule. The function of the AC maintainer at this stage is just to ensure that the chamber does not collapse. So it is kept at 40 centimeters or 50 centimeters. If you overfill, you are going to blow out the chamber. So you don't want the thing. So bottlet is kept at 50 centimeters and it is on only at this stage when you're trying to prolapse the nucleus out. The traditional way of maneuvering the nucleus out with an AC maintainer is to just press on the scleral lip and it has to pop out. But that cannot be used in this posterior polar cataract, because that increased hydrostatic pressure itself can blow out the posterior capsule. So you're using a phaco sandwich technique with OVD, but you're also turning on the AC maintainer. So this is the stage at which the AC does not collapse, and that's the reason why I believe you have a better chance of preventing the posterior capsule rupture. So then the next steps would be as usual. There's nothing much in this case. So this is something which I've tried and I find it very helpful. So maybe there are many pioneers here who have used AC maintainer much better, in a better way and in longer way than me. So, but I find this is helpful, which is what I have been doing for the last maybe a year or so. So during this step it is off, and this is done under dispersive OVD only during extraction of the nucleus. If there is no AC maintainer, the chamber is going to collapse at this stage, but you're going to keep the AC maintainer on, and this would prevent that the collapse of the anterior chamber. So I think with that, to save some time, I'd like to, do I have some time, sir, or is it over? I think my time is up. So thank you for the opportunity, sir. Thank you so much.
Thank you, and compliments on your, very first-class videos.
Thank you, sir. Thank
to
you.
show a capsular tear consistently is not easy. So
Thank you, sir.
Well done, thank you.
Sir.
Very good. We now invite Dr. Jaydeep Kakadia. Dr. Jaydeep, talking about LaserX, the new slit lamp marking system for astigmatism management.
Jaydeep Kakadia has many innovations to his name. He is a genius, and we are happy and lucky to have him with us. Yes, Jaydeep.
Thank you very much, sir, for the kind words. It's with the voice, please. Hello, dear friends and colleagues. Today we are very happy to introduce to you LaserX, which is a laser-assisted toric axis marker, which is a great help for toric IOLs or for astigmatic keratotomy, and also for astigmatism control by on-steep axis incision placing in phaco or MSICS surgeries. LaserX is very helpful and useful for Dr. Boramani and Bali's CICS technique. LaserX is a small slit-lamp mounted modular device having two powerful laser guns. First, the slit is made horizontal at 0 to 180, then with the first press of foot switch, very low power two aiming lasers come on, and then the slit is brought to cross the center of the pupil, and with the second press of the foot pedal, two powerful flash shots will create two linear burns marked on the test paper. After numbing the conjunctiva with proparacaine eye drops, the patient is taken on slit lamp and the head is best aligned. With the other eye closed, the patient is asked to fixate on this central red target light, which also gives a red Purkinje 1 image on cornea, denoting actual and real the position of visual axis in the pupillary area of cornea. After bringing the horizontal slit in the corneal center such that it passes through or just under the red dot Purkinje image, the laser shot is fired and two marks are done on cornea in microseconds. This is how LaserX marks look on table. Marks remain as is, varies throughout the surgery, and they stay also afterwards for many hours. LaserX marks stay as is for about 12 hours. So we can do marking in advance few hours before or just few minutes before the surgery. Another case. Same case on table. Notice the clockwise cyclorotation in the supine position. It is also a good method to do laser markings before dilating the pupil, keeping the slit horizontal and passing the slit through the center of the small photopic pupil. In this way, it is easier to align at 3 and 9 o'clock position. This 405 nanometer 5 watt near UV visible deep blue laser is completely and only absorbed by the corneal epithelium. These marks, they last for about 8 to 10 hours and they don't cause any pain or foreign body sensation in post-op period. Marks are only superficial, just the epithelial. They are painless and they disappear in less than 24 hours without any scarring. Intraoperative secondary marking with or without ink just by the pressure of desired axis can be done by Gimbel-Mendes ring or RC Shah toric marker. For those of us who cannot afford the high-cost digital image-guided toric marking systems, much less expensive LaserX is a good and equally effective and equally accurate alternative. LaserX module can also adapt a 4K video camera, so it can also convert the same slit lamp into a video or photo slit lamp. Recently, we have also converted one old Jawel Shears keratometer into LaserX in which laser guns are housed in these two boxes, and the whole bar can be pre-rotated to mark the desired axis, so we don't need to do secondary markings on table. Primary markings are the final markings. At the rate of marking 50 to 60 patients per day, these solid-state laser guns will work for over 30 years non-stop without any periodic maintenance, AMC or CMC. We have done over 4,000 cases by now at 4 centers with excellent and accurate results in each and every case. Accuracy of LaserX is matching to that of Varian and Callisto. LaserX is available in 4 options: just the LaserX module for existing old slit lamp, LaserX plus Video Glow for existing old non-photo slit lamp, LaserX with a new slit lamp, or LaserX plus Video Glow with a new slit lamp. By the way, the name LaserX is coined by conjoining 2 words laser and x-axis. Please don't worry about minor head tilts, in fact up to 14 degrees. The compensatory ocular cyclotorsion in sitting position will correct and keep the eyeball always in vertical real reference position, and in fact this compensatory cyclotorsion is one of the survival reflex. Actually, not being able to keep the eyes in erect position in tilted head position is a neuropathology, so please don't worry much about this. This is the link for an interesting 13 minutes video from Steve Mold about this erect eyes even in tilted head position. Let us try this. Please tilt your head to your left or right. And you can notice that the horizon in this scene as well as the screen will appear horizontal only and not as tilted. Here, please note that the nasal laser mark is always more accurate because the temporal mark may look slightly misaligned in few cases due to the unequal slope of cornea, especially in cases of asymmetric bow tie astigmatism with or without the skewed axis. Please don't worry or bother too much because astigmatic corneas are almost always optically never perfect. My excimer laser does not have automated cyclotorsion error detection and correction, so employing this zero line function, I use LaserX markings for this purpose to find plus or minus axis shift manually. Thus, LaserX is useful not only for cataract surgeries but also for ICLs and laser vision correction surgeries. Thank you very much for your kind attention. Thank you.
Next. Yeah, thank you, Dr. Jagdeep, and it's really fantastic. And now the next speaker is Dr. Narendra Singh Verma, who is going to talk about.
Good afternoon, everyone. So my talk is SIA, a friend or foe for MSICS incision. So SIA is defined as the flattening effect in the axis induced by the incision, which is made on the cornea, and it will give some refractive outcome. So if we see the prevalence of corneal astigmatism in cataract patient, 97% are having less than 3 diopter, which can be totally corrected by MSICS incision, and 3% which are having more than 3 diopter, we can reduce some astigmatism in these cases. So if we compare, we will see how we can correct the astigmatism. There are 2 methods, one incision based and second is toric IOL. So toric IOL are costly, they are contraindicated in some cases. Incision based are economical, easy, safe. But the main problem is that predictability about the post-op outcome is lesser in the incision based estimate correction. So SIA is a friend if your incision size is customized and you have taken the incision on the steep axis. For the unplanned incision, it is a foe. So MSIC incision size ranges from 2 mm to 7 mm. Our aim is that we want to correct the post-op refraction. We want to keep it between less than 0.5 diopter. So 0.5 diopter over corrected or under corrected. So we are getting 1 diopter range of error. So I will show you a study in which in 80% of cases we achieve the post-op refraction less than 0.5 diopter. So to make SI as a friend for MSICS, we have to customize the incision size. For this, we have to calculate the flattening effect which is caused by the SIA, and we have to mark the steep axis properly at the perfect place. So for calculation of SIA, we have developed this SIA calculator. You can access by this QR code or by the URL. So this calculator is based on polar and vector method both. So those who want to do toric lens, there's on the upper part here this centroid SI is calculated same as by the Dr. Warren Hill method. Centroid SI, you can use this for toric calculator, and the lower part is the polar method. In this polar method, so this polar method measure the flattening effect. It measures two components. On the left side is the flattening part and right side is the steepening part. And there is only one input data sheet which is easy to use. You can select any combination, any size of incision, site of incision, so you need not to fill multiple data sheets in our calculator. This is the study done last year in the Medical College Thane. So they have used this high-end, this Topcon Aladdin topographer. And this is the study. They have done 102 cases. The patient who can't afford the toric lens, so they try to reduce the astigmatism by 3.5 millimeter main phaco incision and 3.5 millimeter OCCI. So you see that in 99% of cases, the cases are lying on the left side. They are lying on the left side, so there is flattening. Only in one case there was steepening. So this is the polar method. Here we will get the centroid SI value, which is indicating the flattening, how much flattening is there. In this case of 3.5 millimeter main incision and 3.5 millimeter OCCI, it was 1.28. So if we'll take the range 0.5 diopter less than this and 0.5 diopter more than this, it lies between 0.78 to 1.78. So if we'll draw these line, so 80% of cases are lying in this. So if we are, so what was the conclusion? We have seen that some people are saying in phaco, sometimes there is steepening, sometimes there is flattening. We can't predict the SI, how much will be there. So what conclusion we have drawn? That predictability of post-operative result in MSICS incision or larger incision is better if they are taken exactly on the steep axis and incision size is larger. So in this case of 3.5 millimeter, in 80% of cases, we got the post-operative correction between the range of 0.5 diopter. So this is our calculator. So you have this. This is also having toric analyzer. This is MSICS nomogram, which we have made on the Dr. Boramani sir's some data. You enter the steep axis, flat keratometry and steep axis, and wide to wide, which is optional. It will give you the basic nomogram, how much chord length will correct, how much SIA, and how much will be remaining. This is SI calculator data sheet. This is the input data sheet. So only few pre-op keratometry and post-op keratometry, you enter this, and you will get the result both by like Dr. Warren Hill, centroid SI for the toric lens, and the lower part is, this is the lower graph is for the flattening effect. So SI is a friend. If you are able to customize the incision size, you have to calculate SIA for your all incisions, and you have to mark the steep axis. You have to eliminate the error due to head tilt and cyclotorsion. You can use any type of marker, bubble marker, pendulum marker, some digital markers are also there, and now this real-time marking system is also there. So these are some apps which are available on the mobile, iToric app, and these are Toricam and Precision Toric apps. These different apps are there. So this manual marking method is 3-step method. In first step, we are measuring the amount of astigmatism. What is the amount of astigmatism? Then preoperatively, we are marking the reference marking. In the last, during intraoperatively, we are marking the steep axis. So if we are not doing reference marking, there will be the cyclotorsion error.
Yeah. Thank you.
Thank you, sir.
Yeah, before we take the questions, I want to introduce our friend Ivan. He is from Fedorov Institute. Please come. A brilliant surgeon, and when I was operating in Fedorov Institute, he was helping me there. So I have the pleasure of introducing you to the audience. Wonderful surgeon. So,
thank you.
Nice, Ivan. Yeah, you want to tell something?
Yes. Hello, our colleagues. I am ophthalmologist from Russia, Moscow. I do some cataract surgery, cornea surgery, keratoplasty surgery, and I'm very glad to see you. I'm very glad to be in India. It's a very wonderful country, very wonderful. I saw very wonderful people. I like India. Thank you.
Thank you.
Namaste.
So, is there any questions? No question. Thank you so much.